Good evening, everyone, and a very warm welcome to our speakers and participants for today's discussion. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my pleasure to welcome you all to this session of National Aplastic Anemia Forum, an initiative by Voice of Healthcare and supported by Bharat Serum and Vaccines Limited. This virtual forum has been designed to bring together leading experts to discuss the management challenges and evolving treatment landscape of aplastic anemia, particularly in low resource settings where access to timely diagnosis, advanced therapies, and specialized care can often be limited. We are privileged to have with us a distinguished panel of experts who bring extensive experience in hematology, oncology, and bone marrow transplantation. Let me briefly introduce our esteemed speakers for today's discussion. Dr. Asif Iqbal, Associate Professor, Medical Oncology at Dr. B. Borooah Cancer Institute, Guwahati. Welcome to the session, Dr. Asif.
Thank you.
Dr. Uttam Nath, Professor and Head, Department of Medical Oncology and Hematology at AIIMS Rishikesh. Welcome to the session, Dr. Uttam. Dr. Sanjeev Kumar, Additional Professor, Department of Hematology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Welcome to the
Hi,
session, Sanjeev.
hi everyone.
Dr. Nidhi Jain, consultant hemato-oncologist at bone marrow transplant physician at Zydus Hospitals, Ahmedabad. Welcome to the session, Dr. Nidhi.
Thank you and hello everyone.
Dr. Subya, consultant clinical hematologist and BMT physician at Kaveri Hospital, Trichy. Welcome to the session.
Good evening. Hello.
And guiding today's discussion, we are honored to have Dr. Dinesh Bhurani, Director, Hematology and Bone Marrow Transplantation at Rajiv Gandhi Cancer Institute and Research Center, New Delhi, who will be moderating this session. Welcome to the session, Dr. Dinesh. Sir, you are on mute, I think.
Thank you.
So, with that, I now like to hand over the session to Dr. Dinesh to take the discussion forward. Over to you, sir.
Thank you, VOH, for inviting me as a moderator. We have a panelist from, I think, all the corners of India. Me and Uttam is from North. Subhaya is from South. Sanjeev is from the center. And Asif is from East, and Nidhi is from the West. So we have all the corners and center from all over India. We are going to discuss today the challenges and way forward, low research setting, the treatment of aplastic anemia. So I'll be asking a few questions to my panelists. We have a distinguished panelist. They all have a significant experience in treating the aplastic anemia in low resource settings. With this, I'll start. First question to Dr. Asif. Does nutrition play a role in improving the outcome of patient with aplastic? I would say outcome, we can say that nutrition as a cause or whether the treatment improves the treatment. So the relation of aplastic anemia with the nutrition.
Yeah, in country like India, of course, nutrition doesn't cure aplastic anemia or it's not a treatment, but malnutrition sure influences outcome. One of the things that we have seen is poor nutrition leads to more infection-related mortalities. So, in patients who are suspected of aplastic anemia, diagnosed as an aplastic anemia, it's very important to maintain the nutrition, particularly high protein diet, and maintaining micronutrient supplementations like zinc, vitamin B12, and folic acid. In this way, we maintain the patient's outcomes which are related to the disease rather than the outcomes which can be modified by the infections and other comorbidities.
Anyone of the panelists want to add how the nutrition makes difference in the outcome? Sanjeev, some additional remarks. You are muted. You're not audible. Maybe you are muted.
Uh, Sir, pediatric aplastic anemia has a poorer outcome compared to the adult patient of aplastic anemia with ATG therapy or cyclosporin and minabol. So probably nutrition has some role. Why pediatric aplastic anemia has a poorer outcome compared to the adult one, while in transplantation have similar uh, outcome. So I think nutrition play a role in patients in pediatric aplastic anemia for recovery. Those patients who have a poor nutrition status, they have a poorer outcome compared to the fair nutrition status.
The voice is not optimal for everyone, I think. Anyway, Nidhi, would you recommend some diet like precautions when you're treating aplastic anemia, considering that
Yeah,
people are neutropenic? I mean, apart from the
right. So,
high diet and avoiding a malnutrition, what special precautions during the treatment of
so
aplastic anemia?
Yeah, so as we know that aplastic anemia patients, they are very prone for getting infections, and getting infections via the diet is, I mean, whatever they eat is also very important. So it is very important that these patients should have hygienic diet. Now, the concept of neutropenic diet, where initially, it was recommended that all of these patients should have only cooked food and they should not have anything which is raw, is changing now with the latest ASCO update guidelines on the nutrition for neutropenic patients. The most important concept is that the diet should be, whatever they eat should be hygienically prepared. It should not be stale. It should not be from outside where bulk food is being prepared. So I usually suggest these patients to be very cautious about what they eat in terms of the taking care of the hygiene of the food preparation.
So you have a patient sitting in front of you, and you're going to start the treatment. What advice would you give it? Subaya, we can't hear you. I can request Dr. Nath. Can you say if you have, I mean, some special recommendations, Dr. Nath? Subaya, we can't hear you.
Actually, as Dr. Nidhi said, in patients with severe neutropenia, we are concerned with the possibility of risk of gram-negative infections, GI infections, waterborne infections, and foodborne infections. So we are usually advising properly cooked food. Fruits, often we earlier thought that fruits should be avoided, but nowadays we know that micronutrients are important. So, and our patients often do not take proper proteins, adequate proteins. So high protein diet is important. We know that albumin, serum albumin, a good level is important to avoid drug toxicities. Many of the drugs are protein bound. So a good high protein diet, micronutrients. If there is any B12 or folate deficiency at the time of diagnosis, that must be ruled out. And during therapy, they must be careful to avoid infections.
Yes, we can say the high protein, hygienic diet with the enough of nutrients, say, including the folic acid and B12, just to make sure we are not devoid of the ingredients. Is it that's what we will say? Uh, okay. The next question is I'll ask Subaya. What is the most critical first step in managing the aplastic anemia in low resource setting? So the first step in low resource setting. Can you hear me? Go ahead, Subaya. Subaya. We can't hear you. Dr. Asif Iqbal, I'll request Asif to answer. First step in the management of aplastic anemia in low resource setting. I mean,
First,
maybe a common to everyone, but if you have
yeah,
something for the low resource setting, we should emphasize. Go ahead.
the first step is early diagnosis. The thing that we in India we face is that patients often come to us late.
Probably the right diagnosis.
Yeah, right diagnosis, quick diagnosis. And for quick diagnosis, we need the patients to refer early. And I mean, if there are a lot of physicians probably listening to this podcast, and it's important to identify the aplastic anemia early, and the way to do that is having any patients who have pancytopenia with a reverse neutrophil to lymphocyte ratio. I think if we identify that any patients with pancytopenia with a reverse neutrophil to lymphocyte ratio will need a marrow examination, then we are going to, and this does not mean that all patients will be aplastic anemia, but at least we will not miss aplastic anemia in that way. And the patients will be referred to the center where the treatment can be given, either transplant or immunosuppressive therapy, before they get a whole lot of transfusions. So it is important that identification. I think this is one of those hematological disorders where more patients are, lost because of delay in diagnosis, where a lot of transfusions are given before even the diagnosis is done and before the initial treatment and the HLA matched donor is searched.
For the physician, how would you suspect, say someone has presented with the infection or bleeding or weakness? What would be the, I mean, when they suspect that something is going wrong with the bone marrow, when they should order the bone, they should refer it or order the bone marrow? Nidhi? I think that's an important critical step for the diagnosis of aplastic anemia. When do you have to
Yeah.
refer, or when do you have to order, I mean, suspect a bone marrow syndrome?
So,
And what important
as we
test the physician can do it before, I mean, when you're suspecting?
Right. So we know that pancytopenia can occur not just in aplastic anemia, but more simpler condition also like megaloblastic anemia because of B12 deficiency. So whenever a patient comes with symptoms of anemia and CBC is showing pancytopenia, hemoglobin WBC platelets are down, they also should look at certain parameters in the CBC and the peripheral smear. So first of all, in the CBC, in aplastic anemia, generally the neutrophil counts are lower as compared to the lymphocytes. The MCV can be, it can be normocytic or it can be macrocytic. MCV can be high in aplastic anemia patients. Apart from that, the peripheral smear examination is very important, where they should rule out that there is no atypical cells in the peripheral smear. They are not dealing with any malignancy, so that also should be done. Apart from that, in the clinical examination, generally aplastic anemia patients will not have any lymphadenopathy or hepatosplenomegaly. So that also clinically they have to see. And sometimes these patients have underlying inherited bone marrow failure syndrome. So looking at the previous CBC records also is important, whether it is an acute presentation or there were pancytopenia was there even in the previous CBC reports, which can also direct them towards certain diagnosis of inherited bone marrow failure syndrome. So I would say a patient presenting with pancytopenia without any prior history, they should also check to the drug history. That is also very important, whether the patient was any medications which can lead to bone marrow suppression and pancytopenia. Commonly used in the community is sulfonamides, so Ceptron can lead to pancytopenia. Certain Ayurvedic herbal preparation can also lead to pancytopenia. So looking at the drug history is also very important. So pancytopenia, no hepatosplenomegaly, there is reversal in the neutrophil and lymphocyte ratio. Definitely, they should suspect that something is wrong with the patient and needs bone. And there is no telltale signs of megaloblastic anemia. So there is no knuckle pigmentation in the patient. The patient is as such nutritionally preserved, and we are not suspecting megaloblastic anemia. So all these pointers they should consider.
Your voice is echoing. If you can figure it out why the voice is echoing, it will be great.
Yeah, yeah.
Dr. Na, so means I think the MCV is very important. So the high MCV, and low, the normal MCV will not rule out low MCV will probably say there's some other cause than the aplastic or the bone marrow involvement. MCV and bicytopenia should raise alarm, and then the peripheral smear should be ordered apart from reticulocyte count. I don't know how commonly the reticulocyte count is ordered and correctly done. Dr. Nath.
Yes, sir. Sir, what is the question?
So, what's your take on this? For the physicians to say when to suspect that there is some bone marrow failure, like Nidhi
Okay,
answered, just
okay, yes. So actually, what we have seen is if the degree of pancytopenia is severe, then the referred case is referred earlier, like platelet of 10,000, 5,000, very low WBC count, very low hemoglobin. Those cases are referred earlier to hematologists. But if the in non-severe cases the diagnosis is delayed more, because the physician sometimes thinks it possibly it would respond to B12, iron, and those cases are delayed. Actually, diagnosis is delayed, marrow is delayed. But usually, very severe aplastic or severe aplastic anemia cases are referred earlier. One thing is very important, along with the bone marrow, flow cytometry must be sample must be collected. Chromosomal studies must be done. Peripheral smear obviously must be done because acute promyelocytic leukemia or AML with low counts sometimes is missed, and patients can sometimes die even before the bone marrow biopsy report comes, because by that time ATRA has not been started and platelet transfusion has not been initiated vigorously. So rare cases sometimes happens, but early referral, early bone marrow, molecular flow cytometry, cytogenetics, sometimes molecular test saves lives and leads to an early diagnosis and initiation of therapy. And sometimes we have seen APL cases, sometimes physician starts GCSF. I think the others must have also experienced thinking that it is aplastic or bone marrow failure. GCSF is started and those patients diagnosis delayed, WBC count increases. So early referral and early bone marrow along with the ancillary tests, including flow and cytogenetics.
Sanjeev, how important is, say, history in the diagnosis in aplastics, especially for aplastic anemia?
The history is very important. Many a times, occupational history that hints towards exposure of some chemicals, carcinogens. Second is Ayurvedic treatment or any other alternative treatment. That is very important history. Many of these patients have previous history of this kind of treatment, and ultimately they land up into marrow suppression and pancytopenia. Probably some of these drugs having some heavy metals or some kind of chemicals which are harmful to the bone marrow. So I think history is very important. Past history of viral infections like hepatitis B, C, these are very important for uh, these patients.
Okay. Dr. Subaya is there? Subaya? Is he? I think he has a difficulty in connecting. Is he there? Okay, we'll go to the next question. Dr. Asif Iqbal, what is the importance of infection management in aplastic anemia patients? So, how would you say the aplastic anemia infections?
So, infection is probably one of the most important determinants of
I think we
mortalities.
need to have a prevention and then treatment.
Yeah, yeah. So, first of all, if I see that we do not, prevention is mainly about that neutropenic diet and isolation of the patient during the diagnosis and during treatment. But we do not use any prophylactic antimicrobials for preventing. But it's very important to have a very low threshold for starting antibiotics. Because the bacterial sepsis is one of the first and most important determinant of mortalities, and the fever may be considered as an emergency in aplastic anemia, and this should also be percolated down to the peripheral centers, because patient develops a fever with a pancytopenia, the patient will develop a very bad infection by the time they come to a higher referral centers for diagnosis and treatment. So infection should be treated as a high priority. Fever should be treated with antibiotics within the first hour. And in long duration neutropenia, they are also at risk of fungal sepsis. So in those patients, it is also important to look for fungal infections, do a chest imaging, and start out an antifungal therapy as well. So, yeah.
Dr. Uttamnath, so the severity of neutropenia and type of infection. So he just touched it. So how severe is the neutropenia? How would you divide the aplastics, and when you had to be very critical, say 1 hour antibiotic and that type of infection?
Sir, mostly they are at risk of bacterial infections, gram negative, gram positive, both, and it correlates with the degree of neutropenia. Fungal infection, sometimes we see some of our patients we having invasive fungal infections like mucormycosis and invasive aspergillosis. But what in our experience we have seen is buffy coat transfusions or granulocyte transfusions can be life saving in the Indian scenario. Sometimes they develop multi drug resistant organisms which are not responding to antibiotics, like even ceftazidime, avibactam, and aztreonam also. So in those cases, in the short term, the use of granulocyte transfusions and buffy coat, irradiated buffy coat transfusions can prove to be life saving in the short term. More so in the acute myeloid leukemia and BMT settings, but we have seen 3, 4 severe aplastic anemia patients getting saved by buffy coat, and bacterial risk is more than fungal.
Nidhi, what about our countries? So in the infections in our countries, few points Dr. Nath has touched it, but specific, not different to the Western world. Mm, what's the specific in regards to infections? So voice
So
is going.
now, sir, is it better?
Going.
Probably from two devices you have connected.
No, no, I've connected from one device only, but still it's
You
I've
can
made the echo
you can
cancellation
reconnect.
button.
You log out and
Correct.
reconnect.
Okay.
Okay. Till then, I'll ask Asif. What's your take on the
Dr. Sanjeev
specific?
wants to say something.
Who is this? Sanjeev. Sanjeev, go on.
Yes, sir. Regarding the infection part, which we have discussed, um, to me, AML and acute myeloid leukemia are the most severe, where we have a variety of infections, especially fungal infections and gram-negative bacterial infection. Uh, compared
Here we are
to
talking about
ALL,
aplastic anemia.
compared to the ALL or myeloma. So aplastic anemia is as bad as AML in terms of infection. Usually at the time of presentation, we see lot of fungal infection, and they are very prone for fungal infection. So any like AML, where patient if have uh, febrile neutropenia, and there is any features of pleuritic chest pain, we should immediately start empirically broad spectrum antifungal. That is the key infection control strategy for the patient of aplastic anemia. That is my experience.
Something about resistant gram negatives, Dr. Asif.
Yes,
Yeah, unfortunately, we have a whole lot of MDR gram-negative bacilli going on. In fact, I get patients before diagnosis they are put on Zavicefta. So this is one of the very big problem. And as Sir mentioned, Uttam Sir mentioned that buffy coat preparation can be one way we can actually avoid. Otherwise, we will be running out of antimicrobials very soon. But as of now, I don't think any one of us or any centers will be using prophylactic antimicrobial agents. So we are still relying on early diagnosis of infections and treating accordingly.
Okay, so we have a mostly we were talking about the delay in the diagnosis. how to address these challenges in India. So, any experience of how what would you advise to the physicians and others, Dr. Nath, regarding the challenges related to the delay in diagnosis and delay in treatment? There are two. One is a delay in diagnosis, and then the patient keeps going around because so there is a delay in the treatment too. Dr. Nath.
So again, so we need to sensitize the physicians regarding the need for early hematological referrals, early identification of cytopenias, and need to avoid use of drugs like steroids and sometimes other drugs like GCSF empirically in the hope of curing cytopenias. Sometimes we see several patients of aplastic anemia or even leukemias are getting treated with steroids, which is delaying the diagnosis. Sometimes they're receiving GCSF. Sometimes they're receiving romiplastim and eltromopag nowadays. And then they're coming to us. They're coming to us with infections. They're coming to us after 1 month, 2 months, after getting multiple transfusions, 2 or 3 hospitalizations. And any hospitalization increases the risk of colonization with MDR bacteria. So these are the reasons for delay. Secondly, sometimes the bone marrow is done outside in hospitals where only aspiration is done and the aspiration is not done correctly. So it's a diluted marrow and no opinion is given. Sometimes aspiration is done for acute leukemias and the diagnosis is written as possibly hypocellular marrow. So we are missing diagnosis of acute leukemias in cytopenia patients. We are missing diagnosis of aplastic anemias because bone marrow biopsy is not being done. These are the frequent causes of delay in diagnosis.
Nidhi, there are challenges in the delay in the diagnosis and the delay in the treatment. How would you address that? What advice would you give it to the physicians? What they should do to avoid this delay?
Yeah.
Because I think that makes a difference in the outcome.
Correct. Absolutely, sir. Now am I audible and proper?
Yeah.
Yeah.
Right.
So it's, I think, the most important determinant in better outcome of a aplastic anemia is the early referral, early diagnosis, appropriate diagnosis, and closing or decreasing the gap between the diagnosis and the treatment. Sometimes what happens that the patient gets diagnosed but still they are not counseled well, or still probably they are influenced by a lot of other people, that they will not uh, get convinced for starting the definitive treatment. So for the physicians, I would like to mention that it is very important that whenever a pancytopenia patient comes to you and you have ruled out that it is not due to some viral infection or it is not due to megaloblastic anemia, they should be referred promptly to the center which are capable of making first time only getting a diagnosis bang on. Because from the patient's perspective, I would say that sometimes what happens that they get 2 3 marrows outside which are inconclusive, and then they are fed up, and then they would not like to go to another center and get the bone marrow test done. So the most important thing is keeping a very high index of suspicion, making the patient, convincing the patient that you should go and get a proper bone marrow examination at a center where it is capable of doing a less very bad experiences of patients when they come and tell us that the marrow was so painful that we are not going to get the bone marrow examination again in our life ever. So those experiences, if we make the patient feel prior to reaching the proper center, it becomes very difficult for the patients to turn up at the right time. So physicians should be aware about this entity, and they should be aware that it is a disorder, it is a disease which is a kind of needs a very urgent attention. We just cannot keep the patient under transfusion support. Just giving them blood and platelet transfusion is not the solution for aplastic anemia. They should receive the definitive treatment as early as possible before they develop any infection or they develop issues because of transfusion. So early referral to a center where a bone marrow examination, a proper one, can be done, and treatment can be started as early as possible.
So I think for the physicians, the MCV is very important. If your MCV is normal or high, getting a peripheral smear is important if you have a bicytopenia or pancytopenia. And if you have a cytopenias and you require a bone marrow, we should refer to the center where you can have an adequate bone marrow biopsy done and with the not too much of pain. The people should not be struggling to get the bone marrow biopsy. Anyone wants to add in something to give a message? The pancytopenia or the bicytopenia should click that something is wrong, especially if it is not getting corrected by the B12 or folic acid. You should give us some supplement, have a follow up in a 2 to 3 weeks time, and see whether there is any deterioration. If there is any deterioration or do you have a significant neutropenia, then should have a early referral. Uh,
Yeah.
Anyone wants
So
to add in this?
just one more, what I would like to add is that, as you mentioned, the degree of cytopenias is very important. So somebody who's got a leukocyte count of less than 1,000 or the ANC which is less than 200, sometimes the patient directly presents with the ANC less than 200, the platelet less than 10,000. So there is no point in wasting time thinking about other etiologies. So they should be referred early. So the degree of cytopenia is also very important when you consider the referral.
Sanjeev, how to approach when say the even a transplant or the immunosuppressive therapy is not affordable, not available or affordable. I think availability now with the all the
Availability
hematology.
is not issue, sir, but definitely affordability is a issue. Most of the patient in our practice is not affordable for first line treatment of transplant or ATG therapy. For these patients, cyclosporine or any other immunosuppressive therapy like danazole, anabolic steroid, and even now TPO mimetics, eltrombopag or romiplastim is available. So there should not be any delay in starting this drug if diagnosis of aplastic anemia is confirmed. Uh, we have experienced that many of the patients even respond to this triple combination also very good response. Few patients who have a very low ANC and very severe kind of aplastic anemia, they only did not respond to this treatment, and we should not delay any in starting treatment with cyclosporine and uh, t- uh, romiplastim or eltrombopag uh, combination.
Dr. Nath, your experience, how to take this challenge of not the not available or not affordable.
Sir, as soon as the diagnosis of aplastic anemia is made, irrespective of the severity, usually we start cyclosporin and eltromopag or romiplastim. Most commonly, patients prefer oral medication, so it's eltromopag. And if the patient is relatively young, by young I mean 50 or maybe fit patients, if there is a sibling donor up to 55 or even 60, we can go for a transplant. So usually the patient is counseled for a transplant upfront. And if it's more of a non-severe disease, then many of these patients start responding, the blood count start increasing with eltromopag or other TPO-mimetic romiplastim and cyclosporin therapy. If the disease is not responding to this combination, it's easier to identify earlier. These patients are counseled for ATG therapy or transplant, and they are asked to arrange funds. So younger patients, if there is no matched sibling donor, then we usually go for, ask, counsel them for a mud transplant. That is how things work in India. But for very poor patients, sometimes this is very challenging. So the delay is inevitable in such patients,
How
and they have
important is it? How important is a triple therapy versus dual therapy? Sometimes we just leave it on. See, we get only one chance probably. Patients, most of the
yes.
lower category will have a one chance of treatment. So someone who has a sibling and you are a severe neutropenic, doing a HLA and sending them for the transplant may be worth. But what about we leave it on the dual therapy versus we push for the triple therapy? Mm,
Sir,
So, what is your experience? Would
if,
you
sir,
push
if
everyone for the triple therapy? Or
sir,
I'm
if
talking
the
about
patient is a
senior citizen.
sibling donor, we have seen the cost of sibling donor transplant in aplastic in the government setting is not very much like compared to the triple IST. It would be 1.5 times maybe. Even for patients who are around 50 years of age. In uncomplicated sibling donor transplants, we are doing at around 6 lakh, 5 to 6 lakh. The cost with triple
Your
IST
voice.
and mass sibling donor transplants, early transplant, the cost is not very much because even after triple IST, patients will need transfusions, patients will need hospitalizations for infections. It may not respond immediately within 1 month. Sometimes it can take up to 4 to 6 months to respond. And transplant is a one time, like within two to 2.5 weeks, you know the patient's blood counts are normal. So the overall cost may be actually lower. But for mud, I agree that triple IST may be better. Early triple IST would be
Maybe,
more cost effective than
I just
mud.
want to ask you, you are in the private sector, so would you say someone who has no of money means unaffordable, say, how to approach this standard treatment is not affordable? How would you deal in the private setups? Nidhi?
Yeah. So, sir, so transplant obviously in the private setup costs much more than the triple IST, I would say. And other thing is regarding if the patient is absolutely not affordable, still I would like that the patient should receive the triple IST therapy. So I would refer the patient to a center where the government schemes are there to support the ATG therapy. So at present, probably there are government centers where they have funding from certain government agencies as well as the NGOs as well, where they can get the treatment at some affordable price. So rather than doing anything at our center, which would the patient would not afford, I would refer them early to a government center so that they get the definitive treatment rather than messing around with them and not giving them the definitive treatment at our center.
Sanjeev and Dr. Nath, how quickly you can take patient for the transplant? Say someone has been diagnosed with aplastic anemia, has a 6 lakh or 7 lakh rupees. So today he's been diagnosed and you have all the workups. So when can you take him for the transplant? When he can enter into your transplant unit?
Within a week, sir.
You can take her within a week. Dr. Nath?
Sir, we don't have so many beds, but definitely we give priority to aplastic and severe aplastic anemia patients over leukemia and other diseases. Because leukemia patients you can maintain on some sort of chemotherapy, but severe aplastic anemia patients cannot wait.
So we give a
So
priority
within a
and you can
month,
take
maybe
within a month you can take.
definitely
Dr.
we give
Asif.
priority, and it is rewarding. It is rewarding.
Dr. Asif, how important is ATG? Say Sanjeev was saying start on dual therapy, but how important is to add the third drug, the ATG?
Sir, actually, the third drug is Eltrobobag.
No,
ATG is
no.
actually the
So
first
now
drug.
because the oral therapies, these two are started early. So I think the ATG should be a first drug. So I agree with you, but it becomes a third drug because by the time you talk to them, you can start a cyclosporin Eltrobag on the first day. So that's how that I mean you call it as a first drug or a third drug. How important is ATG?
It's important. And now, actually, we get our ATG at a very affordable rate. And we get a patient assistance program also in our center. So let's say somebody who is 60 kilograms, 40 milligram per kg per day for 4 days cost around 4.2 lakh rupees in our center. And nowadays, cyclosporin and ultramobag are also generic. So the entire cost of triple immunosuppressive therapy, including hospitalization and transfusion, comes to around 6 lakh, 6.5 lakh rupees, and it's done. So if somebody doesn't have a mass sibling transplant, then HLA mass sib, then triple IST is the thing we go for. Because if you go for dual therapy, then eventually they will need ATG at some point of time. most of the patients do not have a complete remission with only CSA and Altrombopag.
Sanjeev, your this one, how important is that the ATG? You said people start responding to the dual therapy, but would you
Sir,
push for the
ATG is very important drug, no doubt about it. But sometimes affordability is the issue at our center, and in that situation, we start doublet. Uh, for non-severe patients or a severe aplastic anemia, most of the time it is not issue. But very severe aplastic anemia, obviously, they are not going to respond. They will require ATG or transplant, and we counsel every patient for either ATG therapy or transplant. Especially pediatric patient, we push for transplant. But for patients who are 40 plus, we don't delay for ATG therapy. As soon as possible, they can arrange money for and donors for ATG therapy. We take them for ATG therapy.
Dr. Subaya is there or he is gone? He's not able to join or what happened? Is any information about Dr. Subaya? Okay, anyone disagree that the ATG means we need to be on triple therapy if possible? Uh, any more comments on dual or versus triple? Okay, what government initiatives exist in supporting the aplastic anemia patients? Can someone summarize it? What is existing and what is required? Sanjeev or Dr. Nath?
Whole India is supporting all the pediatric patient of severe aplastic anemia for transplant, uh, for matched sibling donor transplant. And for adults transplant, there is no support system, but PM fund, CM fund, or even in Ayushman, we can have some fund for transplantation. And usually transplantation in match sibling donor transplant in government sector doesn't cross beyond 10 lakhs. Many of transplantation of severe aplastic anemia we have completed even in 6 to 8 lakhs. So I think funding is not a issue. Most of the patient gets fund, and mm, mainly match sibling donor is a concern. Many of the patient doesn't have match sibling concern, and we cannot blindly recommend every patient for haploidentical transplant, because uh, doing haploidentical transplant is not a big deal, but post-transplant complications are very important, and that also cost money.
Your
So
voice
if
is break.
uh,
Yeah, good.
so if they have fund for transplant complication also, then only we post for haploidentical transplant as a first go in aplastic anemia. Otherwise, we are happy with our ATG therapy results, and around 70-80% patient respond with the triple therapy.
Dr. Nath, how is the government support system in your state? I think it varies from state to state, so it's better to talk about the every state probably. Dr. Nath.
So the Ayushman scheme is more or less uniform for across majority of the states, and ATG therapy is not fully covered by any of the Ayushman packages. So it may be partially covered through Ayushman. Okay, and febrile neutropenia packages and blood transfusion packages may be used to cover part of the cost of ATG. And again, early transplants, particularly mass sibling donor transplants, the cost, overall cost in the government setup may be at par with ATG with triple therapy, because the duration of the cost, one time cost is less. Okay. So uncomplicated mass sibling donor transplant, even up to 55 years of age, it could be 5 to 6 lakhs. And cyclosporin
Asif,
cost, okay, you have to continue for 1 year. And part of this transplant cost is also covered by Ayushman, maybe up to 1 lakh. And rest has to be borne by the patient. And sometimes these patients receive from the Chief Minister and Prime Minister Relief Fund. And so the costs are in a lot of way covered by this state and central
Asif,
grants.
Asif,
Sir, our pediatric patients are fully covered by two foundations. One is Impact Foundation and one is HT Parekh Foundation. They support transplantations in kids up to 18 years of age.
these are
And for
NGOs.
adults,
These are non-government organizations.
yes, sir. For adults, we have many public schemes. One is a B.R. Ambedkar ST scheme. So they support transplant as well as non-transplant treatment. But for non-ST patients, I'm talking about our region. Here there is a sizable tribal population, so a lot of patients are benefited. But those patients who are not ST, then we have to go for, as sir said, Rashtriya Arogya Nidhi or Ayushman or PM Fund, but they only support a quota. So let's say, for example, up to 3 lakh rupees. But whatever treatment we do, so rest of the cost has to be borne up by the patient. Yeah.
Nidhi, do you get any help in your private setup in Gujarat?
So private setup, it is difficult. Our hospital itself supports little bit for these patients. So they will give an overall discounts on the overall bill of the patient, but it is not uniform. And we can apply for CM relief fund. So these patients who are undergoing transplant, and partly they can apply for the CM relief fund, and they will get some 30% funding from the CM relief fund. If the patient has borderline finances where partly he can do and partly needs some support, only those patients I will touch in my hospital. Some patients who are, we know that they will not be able to do anything, and little bit finances which they have can be spent in the support care. So for those patients, I will refer them to the government institute, that is GCRI, where they can be managed by schemes. Yeah.
Okay.
Sir, we have a in-house funding of Asadhya Rog Nidhi, which is the revolving fund of 4 crore, and that is only for transplantation, like kidney transplantation, bone marrow transplantation, lung transplantation, and we are the major users. Kidney transplantation program and bone marrow transplantation program are the largest user for that fund. So the best part of that fund is they don't have limit. Even we have used 20 lakhs for haplotransplant if complication has occurred post haplotransplant. So that is a in-house facility at our center for this kind of transplant. Unfortunately, there is no such funding for ATG therapy. That is a problem.
Okay. So, what about this? Means, do we need an interprofessional team to manage aplastic anemia, or anything about the other specialties and having a multidisciplinary teams to manage the aplastic anemia? Dr. Nath, do we are the hematologists are enough to manage, or do we need a more teams?
So the transfusion medicine team is very important, possibly, because if the patient is getting multiple transfusions, then if the patient comes at a like proper time, so if we can get an extended RBC antigen phenotyping, number one, before the patient develops any alloantibodies. Secondly, platelet refractoriness is important. So if the patient doesn't develop platelet refractoriness before a transplant or ETG therapy, then the outcomes are good. So transfusion medicine team is important. Secondly, the infection, the microbiology department is very important. So bacterial cultures, fungal cultures, then the PCRs. Nowadays we need the AMR
Molecular.
gene profile. So panels like the biofire panels in blood cultures, which will tell you which antimicrobial resistant genes are being expressed by these bacteria. These are important. Sometimes atypical organisms are also, like virus and fungus, are also uh, detected by these panels. So the transfusion medicine, the microbiology team, these are very important. The rest can be managed by the hematology team and BMT team. The
So
others might
one
add.
tips from everyone for the physicians for management of aplastic anemia. Just summarize it what we have discussed so far. Sanjeev. So diagnosis, delay in the diagnosis, and delay in the treatment, and the availability of the treatments and the cost of the treatments.
Don't delay in referral any bicytopenia which is not improving by the use of iron or vitamin B12 supplement. Refer to the hematologist.
So if you're not responding to iron and B12, send it to a nutriologist. Okay. Uh, Asif, any message for the?
Sir, I would say that if we have a patient of pancytopenia and we have a inverse neutrophil lymphocyte ratio, we have somebody who has a very low platelet count along with neutropenia, then the patient will need a marrow. It is important that the marrow examination is done at a center where the treatment is given rather than doing a marrow aspiration somewhere else. And we should not delay patients in giving transfusions because transfusion will temporarily halt the progression and patient will get better. But then repeated transfusion is the one thing which will alter the outcomes once we start immunosuppressive therapy.
Can we say that the neutrophil count is less than 1,000 or less than should alarm everyone and should
Yeah.
be send it? So we should look for absolute reticulocyte and the neutrophil count. And even if it is a less than 1,500, make sure you have seen the patient again. To Nidhi, what message you want to give?
Apart from all this, I would mention that counsel the patient for prevention of infection right from the time you are seeing the patient. If the neutrophils are low, tell them that they are supposed to protect themselves from getting infection. So proper isolation precaution, wearing mask, staying away from the overcrowded places, eating hygienic food. So till the time they reach the proper center, at least they should be aware that they are supposed to make shields around them in order to prevent infections. So that is also very important.
Dr. Nath?
Yes, sir, I have a very important message for the physicians, because physicians can help us actually manage better and save lives of aplastic anemia patients, because all patients cannot come to the treating physician, treating hematologist, treating hospital, tertiary center, transfusions to get antibiotics. So life-saving treatment like platelet transfusions, RBC transfusions, IV antibiotics can be pretty much delivered by the local physician, and we are practicing that actually. So the role of the physician who I mean approachable to the patient at his nearby locality is very, very vital. Maybe the state government hospital at the nearby locality, or the private practitioner physician who will be approachable to the patient anytime the patient develops any complication, or patient has a very low platelet count or low hemoglobin, or the patient develops fever or any sign of infection. And we actually practice that. We write in the patient's OPD diary or notes that you have to consult your local physician immediately without delay for these conditions, and what are the triggers for RBC and platelet transfusion, which you must get locally. So this is the very vital role of the physician who is uh,
I think the
delivering the
urgency should be
urgent
come into
treatment
your
to the
mind.
patient.
Neutropenia and thrombocytopenia,
Yes,
there is a
yes,
cutoff when you have a fever, and fever versus neutrophil count and the platelet was and bleeding. So I think this is important. So we all discussed about how to diagnose it, how to suspect it, how to diagnose it, how to avoid delays into the diagnosis and management of aplastic anemia. What are the treatments? How significant to having a triple therapy versus a transplant? Having a one-time treatment which can be a long-term outcomes, and various the government schemes are available for the treatment. In fact, we heard that the patient can be accommodated even in the government setups within a week or within a month. So I think the important the all the we have tried, and the follow up, as Dr. Nath said, the important is the regular follow up, and the communication with the treating center is very important. So we have tried to cover and how to treat it in the low resource setting. Now that thanks to the generics availability and the other things, we are able to cater to the majority of the patients with the aplastic anemia, even in some private setups with some support. And if they cannot afford anything, Then in the government setups also, dual therapy, the triple therapy, or the people, and the even the low cost of transplant has been mentioned, with the immediate effect. So these are the few things which we have taken through. I think the pancytopenia, the bicytopenia should raise the alarm. The severity of the neutropenia should raise the alarm. We should get a peripheral smear done. The bone marrow biopsy is very important. If we are not getting a biopsy done enough, the adequate biopsy, we should refer to the specialist center, because Dr. Nath said that we need to collect some special samples also. Otherwise, patient has to go for the bone marrow test twice or thrice, and they don't like it. So they would like to avoid the treatment versus going for the second or third bone marrow test. So these the few important things which we have discussed. We have a very eminent panelist from the various prestigious institutes which they have put their inputs to this. With this, we finish this session. I hope this has been useful to the listeners and the general practitioners to understand about the aplastic anemia and the journey of the patient in the aplastic anemia. With this, I thank my panelists, I thank the organizers, and I thank the audience for their peaceful thinking, for listening. Thank you. Good night.
Thank you, sir.
Thank you, everyone.